نبتدي السيشن الأولانية. أحب أقدم زميلتي وأختي العزيزة دكتورة مها بندق، هتكلمنا عن predicting and defining transient post-operative hypocalcemia. اتفضلي دكتورة مها.
السلام عليكم، أهلا بحضراتكم جميعا. طبعا سعيدة أن أنا أكون في بداية البرزنتيشنز بتاعة ThyroAlex 16. طبعا بحب أشكر أستاذ الدكتور علياء الأجهوري والدكتور الزميل العزيز دكتور تامر الشربيني على المجهود. إن شاء الله بإذن الله تبقى fruitful presentation. So my topic will be something that is really frustrating to the patient, to the endocrinologist, and to the endocrine surgery to have hypocalcemia post-operative after cases of thyroidectomy. So thyroidectomy is the most common endocrine surgery worldwide. This is why the American Association of the Endocrine Surgeons, they set guidelines for definitive surgical management for thyroid diseases in adults, and it aimed to assist clinicians in the optimal surgical management of thyroid diseases. So thyroidectomy is associated with a list of complications, including both early and late complications following thyroidectomy. Focusing on the early complications following thyroidectomy, we are having hemorrhage, recurrent laryngeal nerve injury, hypocalcemia, wound infection, respiratory tract infection. The most common complications following thyroidectomy in the immediate post-operative period is recurrent laryngeal nerve injury together with hypocalcemia. And experts advocate that hypocalcemia is the most common complication following thyroidectomy, and it's said to be the most critical complication following thyroidectomy. It may be presented with severe form, and it may endanger the patient's life. So whenever the patient is confronted with hypocalcemia or presented with hypocalcemia post-operatively, really the patient is frustrated. And he comes to the endocrinologist. Am I having a transient or permanent hypocalcemia? How can I manage my case? Do I need long-term administration of calcium and vitamin D? Is it related to the surgeon? Is it the fault of the surgeon to have this undesirable side effect? What about the long-term monitoring and follow-up? Do I need to monitor my calcium for long life? And do I need hospital admission for IV calcium supplementation, yes or no? So many questions bob in the mind of the patient confronted with hypocalcemia post-thyroidectomy. Let me, in the next 10 minutes or so, answer these questions in line with the guidelines. So my agenda will entail transient hypocalcemia in the immediate post-operative period, the definition, the diagnostic criteria, the incidence, the etiological factors, the clinical presentations, the predictors and risk factors, the prophylactic measures to implement a yes or no, and tips for management of cases of post-operative hypocalcemia. So starting with the definition, hypocalcemia is defined by calcium level below the lower limit of the normal range for an institution lab with or without associated symptoms of hypocalcemia. While transient hypocalcemia, my topic today, occurs commonly in the immediate post-operative period after total or reoperative thyroidectomy. Transient hypoparathyroidism is defined by hypocalcemia with elevated phosphorus and or reduced PTH levels lasting for 6 months. The proposed definition of hypoparathyroidism entails 4 important indicators: the clinical manifestations of hypocalcemia, whether they are present, yes or no; the biochemical indicators, entailing the serum PTH and the serum calcium levels; the treatment indicators, whether calcium or vitamin D they are indicated for controlling of manifestations of hypocalcemia; and what about the duration, the cutoff level for the diagnosis between transient and permanent hypocalcemia, hypoparathyroidism. As I've said before, and I mentioned that transient hypocalcemia lasts for almost 6 months post-operative. The American Thyroid Association set a statement on definition of post-operative hypoparathyroidism in the year 2018. And the new ATA statement defines 3 types of hypoparathyroidism following thyroidectomy. Biochemical hypoparathyroidism, which is defined by low intact PTH below the lower limits of the lab standard, usually less than 12 picogram per milliliter, accompanied by hypocalcemia. While clinical hypoparathyroidism is defined by the biochemical parameters together with signs and symptoms consistent with hypocalcemia. And we are having a new term known as parathyroid insufficiency or relative hypoparathyroidism, which is typically manifested by clinical symptoms of hypoparathyroidism despite normal range, reference range for the calcium and the BTH necessitating treatment in order to control the manifestations. The ATA diagnostic criteria for post-operative hypoparathyroidism was set to be of a great value in differentiating patients by hypocalcemic symptoms and choosing corresponding proper clinical management protocols. So as for implementation for the role of 2018 ATA guidelines for defining post-operative hypoparathyroidism, a study was conducted where a 5-year retrospective study was performed on patients with papillary thyroid carcinoma who underwent total thyroidectomy between the year 2013 and 2018. They implemented the new definition of ATA for defining cases post-operative. A total of 1,749 patients were enrolled. Almost 521 patients, they were presented with post-operative hypocalcemia. Transient hypocalcemia was said to be present in 458 patients, while permanent hypocalcemia exceeding 6 months was present in 63 patients. Transient hypocalcemia, 1/5 of the patients were presented with biochemical hypoparathyroidism, around 4% with clinical hypoparathyroidism, and only 1.3% were presented with relative hypoparathyroidism. Permanent hypoparathyroidism, 0.5% were consistent with biochemical hypoparathyroidism and 3% with clinical hypoparathyroidism, and no patients were presented with relative hypoparathyroidism. What was very interesting, that parathormone levels recovered between 6 and 12 months after surgery in almost 1/4 of the patients that were assigned before to have a permanent hypoparathyroidism. This is why, as I'm going to mention afterwards, that there is a suggestion to extend the definition of transient hypoparathyroidism to beyond 1 year in order to make sure that the parathyroid regains its function, yes or no. So the proposed cutoff level, as recommended by this observational studies, to extend the transient period or the transition between transient and permanent hypoparathyroidism to 1 year. And why should we wait for 1 year? And why it is recommended to wait for 1 year? Because most auto-transplanted parathyroids, they need almost 2 to 6 weeks in order to gradually recover their function. However, they found that some auto-transplanted parathyroid, they may take more than 1 year in order to regain their function. This is why it is somehow suggested in order to assign the patient as having a permanent hypoparathyroidism with long life calcium supplementation, vitamin D, to wait for 1 year. Moreover, if the blood supply of the parathyroids which were preserved in situ was affected, the central part may undergo a vascular necrosis, and in order for neovascularization and collateral formation, in order to form once more, it may take a long time. This is why the functional integrity of the parathyroids may be prolonged up to 1 year. This is why, upon the observational studies, it is suggested to extend the definition of transient hypoparathyroidism up to 1 year, despite that the exact definition of transient hypoparathyroidism lasts for 6 months. There is an important criteria for definition of post-operative hypoparathyroidism according to the severity, and this is very important. Patients are classified according to the severity of manifestations into mild, moderate, and severe. Mild manifestations where calcium is lower than the lower limit of normal. However, calcium and vitamin D, they are not recommended in order to control such condition. The patient is going to recover alone. Moderate hypoparathyroidism, where calcium and vitamin D are indicated in order to control the manifestations of hypocalcemia associating hypoparathyroidism. Severe hypoparathyroidism, where we need intravenous calcium supplementation together with vitamin D in order to elevate the symptoms, and sometimes we may resort to intact parathormone analogs in order to control the manifestations of the severe hypocalcemic manifestations presented in such cases. So for severe hypocalcemia in the year 2021, last year, a study was conducted analyzing 7,366 patients presented with severe hypocalcemia post-thyroidectomy, where Thyroidectomy was performed in the American College of Surgeons together with the National Surgical Quality Improvement Program between the year 2016 and 2017. Severe hypocalcemia was defined in this study by those patients requiring IV calcium supplementation, those requiring emergent clinic or hospital visit or readmission for hypocalcemia. What was found that around 6% of the patients post-thyroidectomy were presented with severe hypocalcemia. 80% of these patients necessitated IV calcium supplementation. According to the procedure performed, 0.5% were after subtotal thyroidectomy. However, after total thyroidectomy together with or without lymph node dissection, around 12.5% were presented with severe hypocalcemia. What was very interesting finding, and it's a straightforward message for you, that around 1/3 of the patients of severe hypocalcemia occurred after discharge. And even 60% of the patients that occurred after discharge, they were on calcium and vitamin D supplementation. So bear in mind, despite that you may implement prophylactic measures for giving the patient calcium and vitamin D, still the patient may be presented with severe manifestations of hypocalcemia post-operative, addressing that you may need to contact your patient in such conditions in order to avoid hazardous outcomes. High rates of recurrent laryngeal nerve injury, unplanned reoperation, and longer hospital stay were associated with severe hypocalcemia. The risk factors for severe hypocalcemia was Graves' disease, almost double-fold increased incidence, lateral neck dissection, and unexpected reoperations. Accordingly, the authors concluded severe hypocalcemia somehow may be presented post-thyroidectomy, and patients who experienced severe hypocalcemia had higher rates of nerve injury and unexpected reoperation, and we need thorough biochemical surveillance, particularly a parathyroid hormone-based protocol with fine-tuned supplementation in order to avoid unhazardous outcomes. What about the incidence? It is variable because of the heterogeneity of the studies, different diagnostic criteria, different surgical procedures, different experience of the endocrine surgeons. It was set for the transient hypocalcemia to be around the range from 3% up to 65% of the patient may develop transient hypocalcemia post-thyroidectomy, while for permanent hypocalcemia, it is set to be ranging from 0% up to 6%. However, some authors may advocate that permanent hypocalcemia may be present up to 50% of the cases post-thyroidectomy. What about the etiological factors? Accidental or inadvertent removal of the parathyroid glands, damaged blood supply of the parathyroids with subsequent ischemia and congestion, hematoma formation with secondary necrosis of the parathyroids, or direct damage with thermal or mechanical damage. Additional causes of hypocalcemia post-thyroidectomy includes vitamin D deficiency, especially severe forms, acute increase in calcitonin by the manipulation of the thyroid by the surgeon, post-operative alkalosis induced by pain that may be presented with hypocalcemia due to hyperventilation associated with pain, and dilutional hypocalcemia. So preservation of parathyroids with intact blood supply in situ is recommended to be the best way in order to avoid post-operative hypocalcemia. This is why it is recommended by the American Association of the Endocrine Surgeon to have dissection should be performed along the thyroid capsule in order to preserve the parathyroid glands with a strong recommendation. And if the parathyroid glands is not preserved or couldn't be preserved, parathyroid autotransplantation is an alternative method in order to, to maintain the function of the parathyroids. This is why this study was addressed in order to address the parathyroid autotransplantation during thyroidectomy, where they found that despite transient hypocalcemia was somehow of high incidence following parathyroid autotransplantation, mounting up to 32% of this meta-analysis, they found that permanent hypoparathyroidism following parathyroid autotransplantation was around the figure of 1%. This is why it is recommended, if you cannot preserve the parathyroid in situ, go for parathyroid autotransplantation. However, parathyroid autotransplantation is only recommended to be performed for accidental or inadvertent removal of the parathyroids with documented non-viability or compromised blood supply. What about the clinical presentation? It ranges from asymptomatic forms to mild manifestations, including paresthesias, numbness and tingling, muscle stiffness, cramps and spasms, neuropsychiatric manifestations, to the severe forms of laryngeal spasm, seizures, and cardiac arrhythmias. The signs are the famous Chevestek and Trosses signs, the cardiovascular signs, including prolongation of the QT interval with inevitable ventricular fibrillation. Coming to a very important area of discussion of predictors of post-thyroidectomy hypocalcemia, is very important to predict the risk factors in order to decrease associated comorbidities, for short hospital stay, to decrease incidence of permanent hypocalcemia with a better quality of life for the patients. A meta-analysis was conducted in the year 2020 in order to address the risk factors associated with transient and permanent hypocalcemia post-thyroidectomy. 50 studies were including, and this meta-analysis included around 23,000 patients post-thyroidectomy. Almost 1/4 of the patients presented with transient hypocalcemia, and around 2% presented with permanent hypocalcemia. The risk factors studied in this meta-analysis, they were the age of the patients, gender, parathyroid autotransplantation, inadvertent parathyroid excision, Graves' disease, Hashimoto thyroiditis, thyroid cancer, including central lymph node dissection, preoperative severe vitamin D deficiency and vitamin D deficiency as well, preoperative magnesium, preoperative BTH, and postoperative 24 hours BTH measurement. What was found? That younger age, female sex, parathyroid autotransplantation, inadvertent parathyroid excision, Graves' disease, cancer with central lymph node dissection were significant clinical predictors of transient hypocalcemia, while the preoperative severe vitamin D deficiency and postoperative, and not preoperative, and postoperative 24-hour PTH were useful biochemical predictors. However, no significant difference in the preoperative magnesium, BTH, and Hashimoto thyroiditis was significant in patients with or without hypocalcemia. Another study was conducted in the year 2019, studying postoperative hypocalcemia, analyzing the factors influencing early postoperative hypocalcemia, where 2,108 patients who underwent thyroid surgery in this study were enrolled. Postoperative early hypocalcemia was defined as a serum calcium level lower than 8 milligram per deciliter, measured 24 hours after surgery. Another set of predictors were included in this study. Apart from the previously included risk factor, they added the glandular hyperfunction, the preoperative diagnosis, the preoperative serum calcium levels, and the perioperative serum calcium level. It means the difference between calcium level pre and postoperative, the type of surgery performed, the number of parathyroids preserved in situ, the presence of carcinoma in the surgical specimen, and the presence of thyroiditis based on histopathological reports. What was found? That they found that the female gender as well was a strong risk factor, the surgical procedure, and the perioperative changes in serum calcium, which means the drop in serum calcium as compared preoperative with the postoperative, they were good predictors or risk factors for incident early hypocalcemia. And they suggested upon this study to prophylact patients with symptomatic hypocalcemia with calcium supplementation together with vitamin D in order to avoid hazardous outcome. Another systemic review and meta-analysis was performed, including 115 studies. The predictors for transient hypocalcemia included preoperative calcium in this meta-analysis, perioperative BTH, preoperative 25-hydroxyvitamin D, postoperative magnesium level, while the clinical predictors were surgery for recurrent goiter and reoperation for bleeding. What about Graves' disease? Is it a risk factor for post-operative hypocalcemia, yes or no? So many studies in the literature address this point. And an important question addressed in the literature is total thyroidectomy is considered to be morbidly higher for Graves' disease rather than other non-toxic goiters. And what about the risk of post-operative hypocalcemia after thyroidectomy for patients with Graves' disease? And what about hypocalcemia after total thyroidectomy in patients with Graves' disease? There is as increased associated incidence of post-operative hypocalcemia in Graves' disease said to be double increased fold, twice increased fold in the incidence of hypocalcemia, and the proposed mechanism is thyrotoxic osteodystrophy, where there was found a hungry bone syndrome in cases of Graves' disease, where bone restoration depletes the calcium and vitamin D reservoirs. This is why it leads to calcium and vitamin D deficiency with secondary hyperparathyroidism, leading to subsequent post-operative hypocalcemia. And the high levels of PTH circulating for prolonged periods preoperatively decrease the organ sensitivity to calcium and vitamin D and induce downregulation of the parathyroid receptors peripherally. Secondary hyperthyroidism as well increased vitamin D deficiency by producing 1,25-hydroxyvitamin D that converts vitamin D in the liver to in its active form. This is why all of these are proposed mechanisms for increased incidence of post-operative hypocalcemia following Graves' disease. And this is why it is set to have a recommendation by the American Association of the Endocrine Surgeon. Prior to surgery of Graves' disease, we need to give prophylactic calcium and vitamin D supplementation and to replete the patient in order to avoid post-operative severe forms of hypocalcemia. Female gender as well is said to be a risk factor for transient post-thyroidectomy hypocalcemia, and the proposed mechanism was the differences in the effect of sex hormones and the parathyroid secretion itself. Different sexes may have different parathyroid tissue monoclonal proliferation and mitogenic regulators, differences in the anatomy and morphology of the parathyroids between males and females, and high rate of vitamin D deficiency among females as well. Accordingly, shall we offer prophylactic calcium and vitamin D post-thyroidectomy, yes or no, in order to avoid post-thyroidectomy hypothyroidism? It is a recommendation to prevent or manage post-operative symptoms of hypocalcemia following total or completion thyroidectomy by offering the patient calcium and vitamin D supplementation, which is a strong recommendation. The management of post-operative hypocalcemia is according to the severity of hypocalcemia from calcium alone, together with oral calcium, together with vitamin D, and in severe forms, we may mount to IV calcium supplementation in a bolus dose, then an IV calcium drip infusion, and in inevitable cases, we may resort to intact parathormone analogs. And in order for other authors to avoid overtreatment of post-thyroidectomy hypocalcemia with subsequent nephrolithiasis and increased incidence of kidney stones, some authors advocate to give the patient calcium and vitamin D only based upon parathormone figures following thyroidectomy. And the timing of parathormone measurements in the published studies range from 10 minutes post-thyroidectomy up to 24 hours post-thyroidectomy. And parathormone level, please remember this figure, lower than 15 picogram per ml is usually predictive of impending hypocalcemia. The key recommendation, as set by the ATE in the year 2018 for prevention and management of hypoparathyroidism, conduct surgery so as to avoid removal of devascularization of the parathyroids. If it is inevitable, go for autotransplantation of the parathyroids. Either treat the high-risk patients with prophylactic calcium and vitamin D or depend upon the parathormone levels post-operative in order to guide you for the management of patients with calcium and vitamin D. Communicate between the endocrinologist and the endocrine surgeon in order to avoid severe forms of hypocalcemia as well. My take-home message. Post-operative hypocalcemia is the most common complication of thyroidectomy. Severe hypocalcemia may lead to critical outcome and should be clearly addressed. Transient hypocalcemia account for post-operative hypocalcemia less than 6 months. However, we may wait up to 1 year for functional integrity to regain for the parathyroids. The clinical predictors of post-operative hypocalcemia, the female sex, Graves' disease, central lymph node dissection, and thyroid cancer, while the most important biochemical predictors are the perioperative calcium levels and post-operative PTH levels. Post-operative PTH lower than 15 picogram per deciliter is associated with high incidence of post-operative hypocalcemia. Graves' disease is an important risk factor. Prophylactic calcium and vitamin D supplementation is a cost-effective method guarding against post-operative hypocalcemia, taking into account the risk of overtreatment. And by here, I end my presentation, and thank you.